everyone. Welcome to the class. Am I audible to all of you? So shall we start today's session? It is basically the maternal medicine module. So we will be covering two of the very important topics. And I would also like to introduce you to how to proceed with the maternal module and how to score maximum marks, whether you get a this thing, what do you call, structural discussion, or whether you get any simulated patient task. The aim here is to prepare you in a way that whatever comes in front of you, you are able to deal with it with such a confident manner. Whatever disease comes, whether you have seen it or you have not seen it, but you will be able to score best out of it, as if you are really a pro in managing this disease and the patient. So what is the catch in maternal medicine module? That also I'll be explaining you here. And also how to proceed with all the stations, whatever are there in the maternal module. So first of all, just give me a minute. I'm not able to turn on the, yeah, now I'm able to do. Okay, so in maternal module patients, what you have to do is you have to first see how much risk is there of this condition to the patient. Means what is the condition patient is having exactly, and which organ it is affecting in this patient. And you can ask the patient, if suppose there is any syndrome or any disease which has come up new to you, you can always ask the patient, what are your current symptoms, on which drugs you are. So you get to know that which organ it is involving, what investigations have been done, which doctor are you following up with. So do you have any idea about your condition? So like this, you can ask most of the points, and you can, take the idea about the disease. So I always do tell my students to mind map the theory part, the questionnaire part. You need to have all the questions in a stepwise manner in your brain, which will reflect that you know the case and you know what to ask, you know how to deal with the patient. So first of all, whenever there is a maternal medicine module, so I'll tell you how to proceed with it. There are few points which you should keep in mind. First of all, about the disease. See, suppose most of the patient in maternal medicine come for pre-pregnancy counseling, right? So, and few patients, they are already pregnant and then they come. So you need to have a mind map of how you will proceed in these situations. So these are the three blocks which you have to keep it in your mind. First is about the disease. You should always assess whether this disease is an autoimmune disease like thyroid, like GDM, rheumatoid arthritis, or SLE, right? So these are the diseases which are autoimmune, inflammatory diseases, which will involve the multiple organ systems also. And another point is hereditary disease. So if there is these kind of situation, you need to check about the syndrome or the disease, whether it has any specific association on any genetic association or any autoimmune association. So first of all, keep it on the top of your mind map that yes, if it is hereditary, you need to know it is autosomal dominant or it is autosomal recessive. If you know that, well and good. If you don't know, just put the patient in touch with genetic counselor or genetic doctor, right? So you save your neck and you get the maximum marks ultimately the main aim is to score maximum marks and get a clear pass in MRCOG Part 3. Maternal Medicine Module is one of the most scoring module and most losing one also. So in hereditary, so if you know that it is a hereditary condition, but you are unaware which gene it is involving, just put the patient in touch with genetic counselor and tell her that it runs in the family. Okay. Apart from that, if there is no such association, you don't have to involve any other of this field. Then you need to know what are the system it involves, what is the disease. Suppose if it is a connective tissue disease, you need to explain in such a layman language a bit of everything. First, take the idea from the patient about the disease. What do you know about your disease? How is it affecting you? So what are the symptoms you are getting? When did you meet your doctor last? Okay. Did you get any hospital admissions because of this condition? Are you taking any medications because of this condition? Okay. So you need to take the idea from the patient itself. And now, just a minute, I'm just not able to, yeah. So take the idea from the patient about the disease so that you know what you have to ask. Then what are the medications which the patient is using at present? What are the medicines that you are taking? May I know about it? So she'll give you an idea, or you will already got that in the leaflet of your case. So what are the medications you are taking? And if this is an immunosuppressed disease, you need to ask about the if patient is immunocompromised, you need to ask about the vaccination status of the patient, right? And always in the pre-pregnancy counseling, you will ask about the contraception and you will ask about the rubella immunization, right? So rubella is very important in this, and contraception in pre-pregnancy counseling. So these are the points which you have to keep in mind when you are asking about the disease, whether the disease is controlled or disease is in flared status. So this much you need to check about the disease. And then when she comes for the pre-pregnancy, you need to tell the patient, then we may need to make sure that patient is responding to the newer medication and is stable on that. For the vaccination, you need to check the vaccination status, and whatever vaccine is not been given, you will give it. Then coming on to the folic acid thing. Some noises there. Okay. So folic acid also you have to keep in mind. Okay. So we give this mnemonic CRF. So make sure that in pre-pregnancy counseling, you are asking about CRF, contraception, and rubella vaccination and folic acid. Now coming on to the pregnancy part. So in pregnancy, you need to tell the patient that how disease will affect the pregnancy to the mother and to the baby, and how pregnancy can affect the disease. Will that progress? Will that resolve? Will that be the same? Or pregnancy doesn't have any effect? What about the delivery? How the patient can be delivered, okay, whether she has to go for normal delivery or she has to go for cesarean, and when she has to deliver. It is different for all the maternal medicine topics. So the diseases have different impact on the pregnant woman. So you should know it through the NICE guideline of antenatal care for the medical disorders, right? So now I think I have given you a brief idea about the maternal medicine module, that in this part, the extra thing is disease part, for which you have to take some bites in the history, few things you have to change for her, few things you have to add for her. Okay, then what how disease can affect the pregnancy and how pregnancy can affect the disease, and how what precautions we have to do for take for the delivery, and a bit of after the delivery thing, right? One or two liners just about the contraception and breastfeeding. Okay, and about the follow ups. So I hope we are ready now for the cases. So let us discuss our first case. And I would like that now you are many, so active participation of the candidates will be appreciated by me. And I want that somebody should be presenting the case, one of you, and we will be discussing that. So I am just give me 1 minute. I'll be erasing it, and then we can, then we can proceed. And believe me, no need to note everything. Just keep it in mind, make a mind map, make a mind frame, and then we are good to go. Just with the practice and just with the bullet points, you will be able to manage the stations. Okay. So now, let's start with our first case. Is there any volunteer who want to do this case? It will be a structural discussion. Dr. Aparna has raised the hand. Okay, Dr. Aparna, you can go ahead. I will give you a brief idea that it is a structural discussion. I'll be asking you few questions and we will be presenting it in a way that we are presenting it in the examination. Okay, so we will be using a formal discussion in between us. And I will also give you the 10-minute timer. And ideally, you will be given 2 minutes to reading the station. So your time starts now. And it
Just a
will.
minute. I'm unable to, start my video.
Okay.
It's showing that I've been banned to start the video. It needs your permission to start the video.
Okay. So is there anything we can help Anas?
Yes, sure, Dr. JP.
Yeah. That will
It
be great
shows
if
that
we.
the host has disabled the use of my video.
Okay. We'll do something about it. Don't worry.
Um,
Yeah. Just give us a second. Meanwhile,
yes.
you read the station. Yeah.
Is the timer started, ma'am?
Yeah. Just a minute. Just we first doing this video thing. Can you start your video now?
Yes,
Yeah,
ma'am.
I
Now,
can see you up, Dr. Aparna.
yes, ma'am.
Mhm.
Yes, ma'am. Good evening.
Good evening. Yeah, and don't call me ma'am. Just remove that thing from all of you from your mind. We are just colleagues. We are appearing in an exam where we are not supposed to call ma'am or sir. We'll call from doctor and the surname. And if there is no surname, then you can call with the first name as well. Okay? Yeah. So I'll be stopping you and telling you all the small things which really will make a big difference and will make your repo nice repo. Okay, let's start. Your 2 minutes I'm starting, but if you are done before that, let me know.
Is the time done, ma'am?
Okay. So
Hi,
let
I'm
give me a minute. Yeah, start please.
Dr. Aparna, one of the candidates for the exams today. I've gone through the scenario and I'm ready for my structured discussion.
Okay. So hi Aparna, how is your exam going on?
Ma'am?
Okay, you didn't get that. What are your priorities during pre-pregnancy counseling of this patient, Dr. Aparna?
So first, I would like to know about the last menstrual period of the patient when she has had her last menstrual period, and after that, I would like to know more about her previous history, like whether she has had any pregnancy before, and also about the miscarriage that she has had, and the mode of termination that has happened. And I would like to know more about her cycles, her regularity of the cycles. Then after that, I would like to know more about her condition, how and when it was diagnosed, and how is she coping up with the condition, and also about her previous visits. I would also like to go through her records about the same. I can see that she has had lupus nephritis before, and so she's currently in remissions. I would like to know when she has last met her specialist, and also I'd like to go through her records and review her medication. And also, since she is planning for her pregnancy, I would also put her in touch with the specialist to see if the medication that she's taking is safe for pregnancy. And I would also like to put her on folic acid since she is planning for pregnancy. And about the rest of the history, apart from this, I would like to know whether she is having any other medical condition apart from systemic lupus erythematosus, and her surgical history, and her height to weight ratio, her blood group, reservations for blood transfusion if any need arises, and her drug history, her personal habits, and also the support at home. All these things I would like to know. I'd also like to tell her that we'd like to optimize her renal function test before she plans for pregnancy. And since she's in remission, even though she's in remission, I'd also like to know about any uh, symptoms related to urination, whether she frequently had any urine infection or any difficulty in voiding. All these things I would like to know before I could proceed further with her pregnancy counseling.
Okay. How does SLE affect the pregnancy outcome?
So SLE as such can have impact on both the mother and for the fetus during delivery. So most of them who is in remission period, they fare well during pregnancy, but there is also chances of flare-ups during pregnancy. So regarding the maternal conditions, they can have flare-ups during pregnancy, which can have an impact. And regarding the fetus, the baby can grow smaller than expected. There can be UGR, there can be preterm delivery, there can be increased chances of cesarean section and neonatal admission. And also, since she is having anti-Ro antibody positive, there is a possibility of the baby having congenital heart block, and also subsequent pregnancy failure, that is miscarriage also we can expect. And because of the same, we can also expect some anomalies also. And though nephritis is under remission, there is a possibility that it can worsen during pregnancy, and in the mother it can cause increased chances of having hypertension. Since she is also having taking prednisolone, it's very important that we monitor her sugar levels and also blood pressure during every visits. These are all some of the complications that I can expect for both the mother and the baby.
And what do you think about this? You told me about the antibodies are positive. So how would you monitor the baby for congenital heart block?
So regarding the anti-Ro antibody positive, then I would suggest serial scans for her from 16th week of pregnancy, because to see if the baby has any congenital heart block. Because if the woman is found to have antibody positive, anti-Ro antibody positive, then there is an increased chance for the baby to have sudden absence of cardiac activity due to heart block. So I'll monitor her heartbeat from 16th week of pregnancy. And after the gestation progresses, I'll also tell her about the warning symptoms, about how to watch for the baby's movements. If at all she feels any decreased perception of fetal movements, I'd tell her to immediately attend the emergency as soon as possible. I'll also arrange serial growth scans for this patient during pregnancy, because women with SLE usually can have increased growth restricted babies. So I'll also arrange anomaly scans and serial growth scans for her accordingly.
How will you manage this pregnancy overall?
So overall, I would manage her in a consultant-led unit with the help of a team of doctors, which includes a senior obstetrician, a senior radiologist, anesthetist, and rheumatologist, a specialist, midwife, nurse. Everyone will be involved in taking care of her. Once she has become pregnant, I would also, with the help of the expert, review her medications and will give her only pregnancy safe medications. Usually, the drugs that she's taking are well tolerated during pregnancy. And in the initial first trimester, I'd be following her up with NT scan and also with the double marker reports. I'd also start her on low molecular weight heparin and ecospirin, and will put her on high dose folic acid. And after that, since I'll also monitor her complete blood count, renal function test, liver function test, and all the viral markers, urine routine, everything needed would be done at the booking visit itself. And after that, I would be doing anomaly scans, and a series of growth scans would be done. Since she's on prednisolone, I'll also monitor her BP during every visit, and also her sugar levels. OGTT would be done as early as possible, and oral glucose tolerances would be done as early as possible to monitor her sugar levels. And after that, series of growth scans would be done, and the delivery would be the mode of delivery would depend upon would be depending upon the patient's general condition and also the status of the baby. If at all the baby develops any Doppler changes or growth restricted than expected, then we'll plan for the delivery accordingly. The mode of delivery will also be decided accordingly, and this is how I'd be monitoring her during pregnancy.
Okay. And so is there any specific investigation which you would like to do? What investigations before pregnancy? Like she's not pregnant yet.
So, ma'am, I can see that anti-Ro antibody is positive. Apart from that, I'd also see other antibodies also. La antibodies, dsDNA antibodies also. I'd like to see whether she is positive for all these things. And pregnancy support, this is how I'd be doing. And also in the postpartum period, I'll continue the BT prophylaxis, will give her adequate support, that is hydration, and also review her medications in the postpartum period also. Will also prescribe contraception accordingly. And this is how we proceed with the pregnancy and postpartum. These are all some of the specific tests I'd like to do, and also would be monitoring series of renal function tests for her also, ma'am. Since she's a lupus nephritis patient.
Okay. Good. Is this your like first attempts you're appearing for part 3?
No, ma'am, I've already attempted once and I didn't get through.
You did really well. Really well. Just a bit of rebrushing I'll do quickly, right?
Okay.
And if there will be any questions by the candidates, we'll definitely take in the end of the station. I'll correct you as well as simultaneously I would like to, add some points which you all can take up. Thank you so much, Dr. Aparna, for taking
Thank you
up
so
the
much.
case and performing it so nicely. Right? I really appreciate your efforts, and you really know how to proceed with the things. Okay,
Thank
and
you.
that is the only thing for MRCOG part 3. And rest of the things I'll be telling you. You grab some, okay? Whatever
Sure.
have been left. Okay.
Sure. Thank you so much for your nice questions.
Good. Very good. So, okay. So we will rebrush it now. Okay. Quickly we will see. see, my way is always making the charts and circles and, just I'll minimize it. Okay, so let us first see that what is the case. You have to pick it up, okay, for everyone. I'm just not only giving the review about the station which Dr. Aparna has spoken, I'm also giving you how this case has to be taken up in a proper way. So just find everything, listen everything very carefully and note the points. So we can see that patient wants to conceive in next 6 months. She is having SLE. She is for pre-PC, pre-pregnancy counseling. So the most important thing here, as I told you, the in the boxes, in the most in the upper part of your brain, when you are just seeing the station, you will note down SLE. Okay, systemic lupus erythematosus, which is which condition? It is an autoimmune condition. So now you know that you have to tell the patient that it is because of your faulty defense system. So you know it is an autoimmune system, autoimmune disorder. It will affect the vasculature, immune complexes will be formed, and it will attack on the body. The defense mechanism will attack against its own healthy cells, right? So this will be, if you are going to talk to the patient, if you are giving the case-based discussion, you will tell that it is SLE, which is an autoimmune disorder. It affects many organs like skin, joints, right? It affects the skin, it affects the joints, it affects the kidneys, it affects the heart, and it affects the skin as well, right? So now you know the first 2 points, that it is autoimmune, it involves these things, patient is for pre-pregnancy counseling. So now in pre-pregnancy counseling, you will remember the mnemonic CRF and you will not miss it, because every C contains a mark, R contains a mark, and F contains a mark. So you can't miss anything. So you will check for the contraception she is using. You will check for the rubella vaccination in pre-pregnancy counseling always. You will also check whether she is on folic acid or not, right? Then about the disease, you will check what medications she is taking, as it is written here that she is taking hydroxychloroquine, azathioprine, and prednisolone. It seems to be, when they will ask you how you will manage the pregnancy, I will also see which medication she is taking. She is taking these medications and her lupus nephritis is also in remission. Patient seems to be in a remission phase. Her blood pressure is normal. And so we would advise her to, I would advise her to continue with the medications, and because these seems to be safe during the pregnancy and breastfeeding. But I will put her in touch with rheumatologist ASAP, so as soon as possible, so that if there is any alteration or any medicine to be need to be added, they will add or remove or dose adjustment. Okay, these lines you have to speak. And then serum creatinine is 1. It has already been given to you. So yes, we need to tell her to keep herself hydrated, and also the appointment with the nephrologist will be arranged for her. Anti-RO positive. So this is the congenital heart block risk. Okay, so we will talk about it later. So you told about the SLE, autoimmune, you told about the organs involved, you told about the medication in this patient. Then you will talk about the blood test, which blood test you will be doing. So this all comes in the pregnancy management. Okay, so if patient comes for the pre-pregnancy counseling, you will offer her certain blood tests which are required for the pregnancy and for the stability of the disease, right? Also, you will offer her, some are the routine tests, some are the special tests which I will offer her. Special test will include the antibody testing for the patient, right? So like this, you will tell her about the blood test, that these will be Done for you. Then coming on to the effect of the disease on the pregnancy. Effect of pregnancy on the disease. Okay. These two boxes you will remember now. So let us move to our first question. I'm not able to move my slide. Yeah. I'm so sorry for these technical things. Okay. So what are your priorities during pregnancy counseling? Very well covered by Dr. Aparna, but I'll tell you, and I have discussed most of it. Then you will ask the patient, you will take the significant history. In significant history, it will come like, has she conceived ever? Previously also, and how was the outcome of that pregnancy, and what about the disease, was it worsened, and how is the baby? So these few things we need to ask. Never forget baby, never forget the pregnancy period and postpartum period of the previous pregnancy. Okay. And then now, does she has any other medical condition associated, any medicine she is taking, any surgeries in the past, how is the control over the current medicine she is having, that you will ask. Is she updated with her smears? Gynae history is important. You need to speak in the structural discussion. I will ask about her menstrual cycle, and I will also check with the support, because chronic diseases can affect the mental health. She will be requiring extra support if she conceives. Folic acid will be started because she is planning. Contraception will be asked. She will be advised till the time she is not optimized. Then rubella vaccinations, I have already tell you why I'm repeating these sentences, so that you make sure so that it fits directly in your mind and you understand that each and every word I'm telling you carry marks in the exam, right? These are so strong patient safety and clinical knowledge points. So in the exam, if you get these kind of stations, everything will give you 1 mark, and ultimately you get a good amount, good number. So safe drugs, drug allergy, blood group, this comes under patient safety. You'll ask about it. You'll also check about any drug, smoke, alcohol, any addiction. Then you will so this is how you will be moving forward for the pre-pregnancy counseling. And now it is my duty. They have said that what are your priorities during PPC. I will clearly be telling the patient that SLE, this condition, autoimmune condition, may may cause certain problems with the baby and with the mother. To mother, it can cause hypertension, PIH, preeclampsia, thromboembolism, because you are giving a structural discussion. So you need to speak the medical terms. Lupus, anemia, it can cause osteoporosis because she is on steroids. She is on steroids, so it can also increase her chances of having GDM. And also the lupus can flare if nephritis can come back, and SLE can have a flare. In the baby part, baby will have increased risk of miscarriage. There will be growth restriction to the baby. Baby may deliver preterm. Increased chances of stillbirth because immune complexes may block the placental bed also, and giving result to the reduced supply or cut off supply of the blood sometimes. Neonate, after delivering, baby may develop neonatal lupus, so that will be tested later on. These things I need to tell. Also, I need to tell her that because of this situation, she need to be managed in a multidisciplinary team under the consultant-led unit. We will start her on blood thinners because in pregnancy, as such, the thickening of blood happens and the chances of embolism, thrombosis increases. We'll put her on aspirin. It is a medical condition disorder which gives the scoring of 4, and we will start the heparin, low molecular weight heparin, from 28 weeks till 6 weeks after the delivery. We will be monitoring the blood pressure regularly. Also, if antihypertensives are required, we will put her on labetalol. Oral glucose tolerance testing will be done early, and a late testing will also be repeated. Urine will be monitored for proteins, right? Regular blood testing will be done to check for any relapse, right? For the delivery part, so this is all you need to cover in the first question, okay? In your priorities, this is a quick this thing. For the delivery, we will make a delivery plan during the antenatal period only, and we will make sure that she deliver in the hospital. A team is there. She will be given, because she is already on steroid, and in labor she will be needing a stress dose of steroid. So injection steroid will be given, hydrocortisone 50 to 100 milligram IV, 4 to 6 hourly till 6 hours after delivery. And this hydrocortisone first dose will be given when she is in active labor. This dose has been given in the TOG of SLE, and you need to remember it by your heart. Whenever a patient medical disorder, she is taking steroid, you have to give her a stress dose of steroid in labor. Why? Because excessive cortisol demands are there during labor or during cesarean section. So you need to give her steroid. Injection hydrocortisone 50 to 100 milligram IV in the active labor, or if she is going for cesarean, then just before the cesarean, she will be given 50 to 100 mg IV. Then if she is in active labor, it will be repeated every 4 to 6 hourly till the time she delivers, and 6 hours after the delivery. The last dose will go like this. In some of the NHS sites and the RCOG sources, somewhere in rheumatology, this American Rheumatology Association guidelines, it has been given that you have to give the stress dose of steroid till 24 to 48 hours of delivery. But we'll stick to 6 hours, because in RCOG it is like 6 hours after delivery for our purpose. Like for the obs and gynae evidence which we have in the form of TOG, we only have this paper TOG, and it is giving this dose. So you just remember this dose by heart, okay? And steroid cover will be given antenatally, because baby may deliver preterm. So these things you have to speak. If there is a relapse or disease become active, induction of labor will be done between 38 to 39 weeks, okay? Otherwise, patient may go in spontaneous labor. There is no indication of cesarean section because of SLE. It is only maternal or fetal indication, okay? And now coming on to the postpartum period. In postpartum period, there are 3 things, which is A, B, C, R. A is appointment. Next appointment will be at 6 weeks. After delivery, she will be seen at 6 weeks. Breastfeeding will be allowed. Safe medications are there. So there will be, she will be advised to continue those medications. She will be advised for a good contraception to prevent any unplanned pregnancy. And she will be told about the recurrence if the baby develop any congenital birth defect or congenital heart block. The chances of having this in another baby is almost 20%. So recurrence risk will also be explained to her, right? I think I have not added in the baby management about the congenital heart block thing. So here anti-RO and anti-LA antibodies are positive. We will be offering echocardiogram at 18 weeks and at 28 weeks. And heart rate monitoring, very well said by the doctor, that it will be from 16 weeks onward. Does anybody has any query till now, or you want to ask, or Like, are you people getting it, what I'm saying? Is there any question from you guys? Or you want me to repeat anything? You want me to be a bit slower? Just do let me know in the chat box, okay? It is in front of me and I'm watching it.
Thank you, Doctor.
Hi, Dr. Anwar. Is there anything you want me to ask?
Yes, I'm asking about monitoring if the antro is positive. How to monitor the last point.
Yes. So in this, we see there are anti-RO and anti-La antibodies, right? These are big antibodies. I mean,
Yes.
complexes of antibodies, right? So what happens is that these antibodies crosses the placenta at or after 16 weeks of pregnancy. They are able to cross it at that time. And these are the antibodies which attacks on the Purkinje fibers of the fetus, right? They attack on the heart of the fetus. It may cause heart block in the fetus. So we monitor the fetal heart rate from 16 weeks. Okay. And we offer the fetal echocardiogram to see whether the heart is functioning well, all the four chambers are okay, there is no conduction defect, and we watch it at 18 weeks and later at 28 weeks. As late as till 28 weeks, it may cause congenital heart block in the fetus. So that's why we watch this. Okay. And we do echo twice, 18 to 28 weeks. We monitor from 16 weeks onward the fetal heart rate with the regular ultrasounds, which are indicated for fetal growth monitoring also. And it is indicated once every fortnightly, means every 2 weekly. Am I clear?
Shukran. Thank you.
Yeah. Yes. So this is the list of the medicines in the SLE. You should know, suppose right now I have given you the three medications which you can continue throughout the pregnancy. But how do you know that you can continue other or you need to stop and when you need to stop? So just remember these few points. NSAIDs, if a patient comes for NSAIDs, okay, you need to check this, right? Are you taking any, do you have any extra joint pains and aches? Are you taking any medicine, any pain relief medicine? Yes. May I know what kind of medicine it is? If she is using non-steroidal, I mean NSAIDs, ibugesic kind of a thing, you need to ask her to stop. If she is pregnant and using NSAID, you need to ask her to stop. She should not continue beyond 32 weeks because it can lead to PCDA. I mean, premature closure of ductus arteriosus will happen. So, NSAID should not be taken beyond 32 weeks in pregnancy. If she wants to conceive, she should stop it because it inhibits cyclooxygenase, and cyclooxygenase enzyme is responsible, is required for ovulation. Okay. So she should she should not be taking NSAID if she has come for pre-pregnancy counseling, right? Now coming on, but azathioprine drug, fetal liver lacks the enzyme to convert it into the active metabolite, and we know that azathioprine acts through the liver. When liver metabolize it and turn it into active metabolites, it's active metabolites, and then it acts. So it is safe in pregnancy and it is also safe in the breastfeeding, right? So patient can safely continue. Methotrexate, we all know it has to be stopped before 3 months of conception, because 3 months is the wash off period for this drug. So patient come for PPC and she has this drug, you need to tell her that don't conceive till 3 months, use a good contraceptive. We will put you in touch with the contraception clinic. Then MMF, mycophenolate mephitil, discontinue at least 6 weeks before, right? It has to be stopped. Cyclophosphamide, it is teratogenic, stop prior to conception. Some text says that at least 6 weeks. Some says ki immediately before conception that you can stop. Cyclosporin, patient can continue with cyclosporin. It is not teratogenic, and especially in transplant patient. Okay, so she can take cyclosporin, and she can take in breastfeeding also. Hydroxychloroquine, it is safe and it should not be stopped, because if you stop it, it may lead to flare of the uh, disease, right? So this chart is a very important chart. You should read it, learn it. Corticosteroid, safe, continue during pregnancy. But yes, what does it cause? We learn it just now. It causes GDM, it causes hypertension, it also causes osteoporosis. So we need to take care that she take her calcium, she take her vitamin D3, she vitamin D. We do the BP monitoring regularly. For GDM, we do the early OGTT and OGTT between 24 to 26 weeks. So twice we will do the OGTT. So this is the same as I have explained just now. These are just the bullet points, okay? So, but you ensure that disease remission is for at least 6 months before conception, because the chances of a healthy pregnancy outcomes increases. So you need to speak this, right? Smear history, yes, it should be taken. Smear history is something you cannot miss in any of the station, ideally, and make it a habit. Just it take 1 second. Are you regular with your smears? Is there any problem? No, that's it. Done and dusted. Don't put your head in this, okay? If she is not getting it done, it's a patient safety point, because there in UK, cervical screening is a must thing, and you got the chance when patient is with you to assess that she is undergoing the regular screening or not. If she is not undergoing, that's a point, right? And if she has any abnormality, you need to see that also, because in UK exams, one main thing is that you deal the patient holistically. Holistic approach. Holistic is the word. Even if you don't do anything, yet you speak holistic. On the whole, overall, you check her financial status, you check her transportation, you check her support, you check her mental health, you check every social thing about her. If she doesn't have any support, you tell her that you make sure that you just say one word, okay, we will provide, we'll try that, somebody would be visiting you. If she has problem in coming to the hospital, then you can arrange for home visits in some station, in some situations. But you be empathetic and be in like, do not ignore anything. You are not just a doctor, you will be managing her completely, right? So smear history and drug allergy history, blood group history, these histories are important. Okay, in family history, just 3 things. Note down right now and just remember it by your heart. In family history, in maternal medicine module, ask about clot, blood pressure, sugar, because these three will be passed on to her as well, right? And right, like in SLE, you will ask about any medical condition that she has. In that also specifically ask about thromboembolism or clots, blood pressure and sugars, because that can happen, that can affect the pregnancy. And if it is in mom and dad, then also it will affect the pregnancy, and your management will also be affected. Like, you may need to add aspirin, you may need to offer her OGTT early if there is a family history. So in family history, in all maternal medicine pregnancy module, antenatal module, you have to ask. Mariam, do you want to ask me something?
Yes, ma'am.
You're
I wanted to ask that if the patient is on continuous steroids for any maternal medical illness like asthma, so we will see her sugar only twice in pregnancy, like at 24 and 28 weeks, or we have to check the sugars at every visit.
no. OGTT in the NICE, in the medical disorder, right? It is written that 12 to 14 weeks or on the first visit, booking visit, you will do the OGTT, oral glucose tolerance testing, okay? And then at 24 to 26 weeks or 28 weeks, you will be checking it again. If suppose OGTT is normal in the first visit, you will repeat it at 24 to 28 weeks. And if you diagnose in OGTT that she is diabetic already, then you will, you will put her in the GDM category and manage accordingly.
Okay.
Okay. Am I clear?
Okay. Yeah. Just ma'am, I was asking because the patient is on continuous steroid, because like in
Yeah.
this condition, then also we will just do it twice
Yes.
for screening
There is
purpose.
no indication of regular, sugar
Okay.
monitoring. Regular blood pressure monitoring will be there.
Okay.
Okay.
Ma'am,
Yeah.
another thing I want to ask regarding the steroids, in Kunji book, I was solving the case, and it was about Crohn's disease, and the patient was on prednisolone. So in the answer key, they wrote that they will involve fetal-maternal medicine because the patient is taking steroids from the first trimester. Do we need to do any such thing? Because I haven't read this anywhere else.
No, I'll tell you why they are saying, um, though when patient is on continuous steroids, rheumatologist, we are see, it is SLE, so we'll go to rheumatologist. Okay. In Crohn's disease, we will involve gastroenterologist. So they all are medical specialists who are specialized in these specific fields, right? So just the medical team will be there and you will involve the specialist. Specialist is gastroenterologist. Otherwise, for steroid continuous uses, it has been put by some specialist only. So they are following it up. And I have told you the things which are concerned with pregnancy is hypertension, GDM, and osteoporosis. So in the history, need to ask about folic acid. You're taking vitamin D also, right? And here, see, we do not show the importance of vitamin D, right? Why? Because it has not been in our templates and our books. But this is so important to check about vitamin D levels also. When specifically a condition like SLE or any renal transplant or any renal disease patient where vitamin D will be affected, levels will be affected, right? So in SLE, anemia can also be there. So we need to check her CBC. So there will be one common set of testing, but when you are doing the structural discussion, it will be so graceful to say that I will check her complete blood counts because she has SLE and kidneys are affected in the past also, and now also, like creatinine is one. I would like to check her hemoglobin. She's prone for anemia. So if you speak like this, it gives the impression, okay, the doctor knows what is the basic of this, right? So like this you can, and also I'll check whether she's taking folic acid, vitamin D, because it is important for the pre-pregnancy counseling to check, right? Especially if she's pregnant, then vitamin D you need to speak. Okay. In PPC, there is so much in pre-pregnancy counseling that you really need to be very thorough and systematic, and just the buzzwords and like ABCR for delivery, then CRF for pre-pregnancy counseling. These are the points you should never miss. Medication, vaccination, disease, right? So this is how you will proceed in these stations. Rest, just involve the whole team. Multidisciplinary team will be involved. Obstetrician will be involved, consultant obstetrician, consultant rheumatologist, anesthetist will also be involved because there can be so many complications of SLE. Anesthetists need to be involved. Her joints can, she will have joint pains and ache. We may need to involve the orthopedician also. We will involve the, genetic counselor. No, not genetic counselor in autoimmune disease. Mental health support, right? So mental health, we need to involve the psychiatrist or psychologist, also the dietitian, also to look for any nutritional deficiencies. And like this, we can, just speak 5-6 names or maximum names you, and GP will always be there, right? GP will always be there, written information will always be there, documentation will always be there in structural discussion and in simulated patient task. So these are few words which you can't skip, right?
Okay, ma'am.
Shall we
Thank you, ma'am.
proceed? Yeah, welcome. So how does SLE affect pregnancy outcome? So this also Dr. Aparna has really done well. I'm happy. So we'll just, I don't know, I'm not able to move these slides. There's some problem from my side. Yeah. Okay. So pregnancies, how it affect the pregnancy. So pregnancy complicated by SLE have increased risk of. Why increased risk of? If you are doing a structural discussion, tell the examiner that because of the immune complexes and the blockage of the arterioles, so there can be reduced supply to the placental bed, and there can be increased risk of miscarriage, placental insufficiency, fetal growth restriction, preterm birth for the baby. And stillbirth can also happen due to the acute shutdown of the blood supply to the baby, also because of the growth restriction as well. For the mother, it may increase the risk, it increases the risk of hypertension because of the involvement, because of the medication she is taking, like steroids, and also by the SLE itself. So there is a increased risk of hypertension, preeclampsia. So we need to monitor the urine proteins. Also, there can be, because of the antibodies. Okay, in the baby only, you need to tell about the congenital heart block. I always skip this. And for the mother, preeclampsia, GTM, clot, thromboembolism. So these are, and relapse of the disease. So these are the things which can happen. Okay. And risk is highest in the women who have active disease, who have antiphospholipid syndrome, who have lupus nephritis, anti-RO, anti-LA antibodies, chronic hypertension or renal disease. Okay. So this is the, which women have the highest risk. So in this woman also, though lupus nephritis was there, but in the past, she has the antibodies. So risk is high in this woman. So you have to make it clear to the woman that because of these antibodies, we can, we know that the risk to the baby is higher in your case. Okay, you have to explain her that she will need extra monitoring of and extra heart scans of the baby. So this is how you become a safe doctor. When you have some, when you know some subject, you need to highlight the points which will keep you, selectively above the others. What investigations? So if these questions will be put to you, though I did not ask Dr. Deepika, I just asked in the last to her, Dr. Aparna. So in this, we will first check the disease activity with the full blood counts. I would like to check her anemia and urine examination, any proteinuria or any urine infection, liver function test. Her creatinine has already been given that it is 1. So urine for protein creatinine ratio, it is advisable, and complement level are also advisable to see the disease activity. Why? Complement level, that, it plays a part. It stops the immune complexes to form. It stops the antibodies. If the level falls, activity increases. Anti-double-stranded DNA. The more anti-double-stranded DNA, the more active is the disease because it is hitting the cells and releasing the DNA in the bloodstream. So antibody screen, anti-RO, anti-LA, lupus anticoagulant. This is all APLA testing, anti-phospholipid antibody testing. Right? 3 antibodies are there in APLA: lupus, lupus anticoagulant, anti-cardiolipin antibodies, and anti-beta-2 glycoproteins. Then general investigations, we will be regularly monitoring the blood pressure, regularly reviewing the medication, vaccination review, we'll do the renal assessment, and we'll do the cardiac assessment. So do not just think that I've just written the renal and cardiac assessment. It has a major role. Okay. Major role in the sense cardiac assessment, like if SLE is affecting her cardiac status, we need to check regularly. Renal assessment before pregnancy should be done, because if she has nephritic element, then she is at a high risk of the of carrying the pregnancy. So first we need to treat that. Okay. How would you manage the pregnancy? Combined obstetric rheumatological care, continue hydroxychloroquine, low dose aspirin, and from 12 weeks, serial fetal growth scan. From it is always being done by 28 weeks, but if there is anti-RO, anti-LA, then fetal heart rate monitoring will be started from 16 weeks, right? Blood pressure and urine surveillance, monitor the disease activity. Antiphospholipid antibodies are present, low molecular weight heparin and aspirin. Timing you should know. For structural discussion, you should prepare the topics which we know that, okay, these topics can come. So you start preparing from now. Important talks, important lines should always be highlighted. I'll send all of you the highlighted talk of SLE, so that it will be easy for you to remember which line is to speak, which line is giving you marks. Low molecular weight heparin will give you 1 mark. But if you speak that it from 28 weeks till 6 weeks, then you will get 2 marks. And it is like this. Marking is like this. Okay. There are points for every safety point and every clinical knowledge point. And these points are also subdivided. Like 1 point you will be given, 2 point, maximum 2 points you will be given, how much you score, how much you speak, till what line you end. So just prepare accordingly, and believe me, it will become so easy till the time you reach your exams. It will be very easy for you to remember these points, speak these points. You will be so pro that you know what I have to speak and how I have to take out marks from the examiner. Anti-RO, positive fetal surveillance, we have repeated it many times now. Patient safety point is hydroxychloroquine. Patient should not stop hydroxychloroquine. Advise her that this drug is safe. Do not stop any medication by yourself for getting conception, okay? Because some women, or most of the women, think that these drugs, all of these drugs are teratogenic, even steroids are teratogenic, and they stop them, and then they go for the pregnancy, and flare happens. So you need to explain it to the patient when you end, when you come to an end, that I'm so happy that you come for the counseling, you come for the advice. It is a very good step you have taken. I would advise you not to stop any medication on your own. Otherwise, the disease may come back again, and the pregnancy will not be having a good outcome. I will, and if she says, I'm not sure whether, this is a safe drug or not. If she is not convinced by you, book an appointment then and there with her doctor and tell her to go, make an appointment, discuss with your doctor and come back. We'll talk again. We'll talk again. Sometimes some patient, they doesn't want to listen. It is there, they are all taught well in these exams that, they have to stop you every time. So you just say, okay, don't worry. We are not, we are not in a hurry. We have time. You go there, talk to the doctor, come back, we'll discuss again. You can come with your partner. We can, I can tell my consultant, we'll have a group meeting. So like this, try to take everybody in. In a difficult situation, the only mantra, or, only key point is not to be alone. Whenever patient put you, or this simulated patient task, if somebody is putting you in a difficult situation, involve the team. Don't be alone, and you'll be immediately out of that situation. Okay, believe me. So you can see it in your exam also. . So I think we have reached to the end of this station. Now the another station is a simulated patient task. Any volunteer who want to do the station? I will be your patient, a good patient in fact. So you, any one of you can attempt. Anybody? Come on, guys, you're too many. I can see. You need to come forward.
I can do. Can I?
Yeah. May I know your name?
Natalia.
Okay, hi Natalia. How are you doing?
Nice. Thank you.
Yeah. So
Actually,
let
I
us
didn't
start.
read about it.
Pardon?
I didn't read. I was not prepared for this, but I will try. Okay.
You need to try. I've told you a few
Okay.
points that you have to go through the go by the chart or mind map. Just keep on asking whatever points I've told you. Just ask those at least. Okay. Simply go. Just go. We'll see, and I know you'll do better. Okay. So just keep your confidence so high. Shall I start the timer? Though it
Okay.
is only,
Fine. Stop.
yeah, it is only one slide for you.
Okay.
Okay, your time is over. Shall we start?
Okay. Okay. Hello, I'm Dr. Nazamin clinic today. May I confirm your name and age, please?
Yeah, I'm Mrs. John and I'm 29 years.
Excuse me. How many? How many years?
29. 29.
29. Okay. Okay. Thanks for coming, Mrs. John. As I know from your note, you are 8 weeks pregnant and you are known case of Marfan syndrome, isn't it?
Yeah. Yes, doctor.
Uh, do you want to speak about pregnancy and Marfan syndrome and any other concern for today?
No, doctor, just I was worried because, though me and my partner, we are in a stable relation from last 2 years, and we were we are fond of children, but because of this condition, my partner was also a bit worried that we should opt for the pregnancy or not, we should go for it or not. But we had an unprotected sex last month, though I had an I pill as well, emergency pill. But then also I conceived, and we think it is a gift of God now. So I'm really interested in having the baby.
Mhm. Your concern is valid, and I will address your concern soon. But before, I would like to ask you several questions to know you better, and then I will explain your condition, how pregnancy influence to your disease, and how disease influence on your pregnancy. And then I will give your patient information leaflet and write back to your GP. How does it sound?
Yeah, that sounds good.
Okay, Mrs. John, so as I understood from your conversation, you say that you don't have baby and it is your first pregnancy, isn't it? And you used
Yes,
before contraception. Which
yes,
contraception did you use?
we were using condoms.
Uh-huh. Okay. Tell me, please, are you updated with your pap smear?
Yes.
What about your period? Is it regular?
Yes, doctor, it is regular now, but sometime, it may get delayed by 5 or 6 days. I hope it's okay.
And where was your last menstrual period?
It was approximately 2 months back.
Uh-huh. Okay. And did you have any sexually transmitted disease treated in GAM clinic, you or your partner?
No.
Mm-hmm. Okay. Sorry, I ask about this because it helps me to manage you better. And please tell me about your disease, Marfan syndrome. Did you when did you see your doctor last time?
It's around 3 months, 4 months, I think. Yeah, 4 months back.
4 months back. And did you do your echocardiography that time?
You mean the heart scan, echo? Yeah, yeah. I got
And
it done, and it was all normal.
do you have it with you? And will you give me your consent? I will go through your notes and I will check it. Is it okay for pregnancy? Everything?
Yes, sure.
Okay, thank you. And any can you tell please any blood pressure problem? Do you have any blood pressure problem?
No, doctor.
And
My blood pressure is always controlled. I am taking
mhm.
losartan. Right now, my blood pressure is, they measured, it is 120 by 80, I think. I am on losartan. He has put me on losartan, which is suiting me the best. I have no issues. I'm on it from past, I think, 3 years.
Mrs. John, I'm sorry to say you, losartan is not good medication during pregnancy, so we should cut it. Don't use it anymore, please. We will change it. You will be change it soon. I will explain you at the end. But now, please cut it, okay? Because it can damage kidney of your baby. Okay. Please tell me what about other diseases you have. What should I know? Hello? 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 Hello?
Am I audible?
Hello?
Yeah, yeah.
Yes.
Can you hear me?
Yes. Yes. Am I
Okay.
audible also?
Yeah, yeah,
Any
you
other
are
disease?
audible.
Any
No,
other diseases I should know about it? Any
no,
surgery? Huh?
no, no surgery.
Any drug except losartan? Do you use folic acid?
No, for my heart rate, they have put me on propranolol.
Uh-huh. Any other drugs?
No,
Any allergy?
no,
Cigarette smoking? Alcohol?
no,
Illicit drugs? Sorry, I asked. Um,
no.
what is your weight and height ratio?
Doctor, it is 27, I think. Yeah.
Okay, please tell me about your family history. Does anybody in family has any problems with diabetes or thyroid or blood clots or maybe
No.
congenital disease which running in family? No. Okay. Do you have good support at home?
Yes.
What do you do for living?
I'm a teacher.
Okay. And do you have like exercise heavily or something like connected to physical activity?
Actually, previously, I was going to gym, but then I was feeling breathless and I was not comfortable. So doctor said that, I should not do heavy exercises. So I'm comfortable with my routine and, I can walk till my school, I can go walking and I'm okay.
Okay, nice. Just several questions I didn't ask. I want to ask you, do you feel any nausea, vomiting,
No, I'm comfortable. Not much nausea.
any abdominal pain, any spotting, bleeding from down?
No.
Okay, thanks for sharing this information. And with your consent and with presence of chaperone, my nurse will check your blood pressure, pulse rate, and is it okay?
Yeah.
Okay. So, Mrs. John, I will explain your situation. You have Marfan syndrome. It is can affect pregnancy, and pregnancy can affect this syndrome. Because of mostly connective tissue is very loose in body, so it can affect your heart and vessels, big vessels. So because of increased amount of blood inside your blood vessels during pregnancy, it can be dangerous for you if you will have certain conditions such as your diameter of your aorta more than 4 centimeters. But I will go through your notes and check. And it should be checked during pregnancy in every 3 months, every trimester, if you don't have any problem. And if and you will be managed by a multidisciplinary team, which will include heart specialist, perinatologist, anesthesiologist or sleep doctor, and also we will involve genetic specialists. Genetic will counsel you and what is possibility of your baby to have it, and we will ask also about your husband. Does he have anything similar in his family? Am I clear?
The doctor, my baby can also have it.
Actually, this is condition, which is it is like autosomal dominant. It means that this condition in 50% of babies can come to baby in 50% of pregnancies.
Oh my God.
You will be don't worry, it isn't its severity not much possible to predict, and
Okay.
neonatologist also will be involved. Also, you will be your blood pressure will be checked in every visit, and you will be your disease can influence on pregnancy, like you will be in more risk for decrease baby's growth and blood supply to baby, and um, blood pressure can also increase during your pregnancy. Am I clear?
Okay.
And
Your time is over, Dr. Natalia. You want to continue?
actually, I didn't speak yet
Didn't
about
finish. You didn't
that
finish.
it can. Okay, it can be natural delivery like this, and it can be after you can breastfeed like this, and after it, you should now you should start also folic acid, and consultation with cardiologist will be administered, and then you can use after pregnancy contraception, any contraception which is
Safe.
which is exist. Yeah.
Yeah. Okay. So shall I start with the feedback?
Yes.
First of all, yeah, you are getting you're thinking that what will happen if I'm not able to speak correct. So first of all, you don't need to think like that, okay? Just stick to the basic template. Basic template means the basic things map. I have told you that, just start. Just start and just don't worry what if you are leaving anything, if you are missing onto anything. And be very clear in your mind what you have to ask next. This will come with practice. A lot of practice you have to do now. But initially you have picked up very nicely. The only thing I found was that time management. You took history for about 6 to 7 minutes. Any history, maternal medicine, urogyne, these are the biggest, longest histories. So you have to finish it in 3.5 minutes. Okay, 3 to 3.5 minutes. And this time management will come with the time, right? Time, you have to give time for being on time. So now you covered it well. You asked me NYHA also. I was happy about it, but there were few things. You one thing was the which I liked the most is you involved the GP and you documented the thing in the beginning of the station. So in any station, though, it is advisable to involve the GP documentation, written information. Just give it during the introduction also. Good opening sentence, and these are these gives a kick to your station. So in this, there was nothing much in the slide. So I'm just moving forward, and we will, other than that, when you were telling about the Marfan syndrome, you would have taken the idea of the situation, right? That, do you have any idea about your condition? That would have saved your time. And also you would be getting to know about the syndrome, that what all is being affected. You asked me about the losartan. I asked you, is it affecting my baby? Because you said it's not a good drug, right? So if you say like this, patient become panicky, and they think that it has already harmed the baby and it is their fault that they have come late. So just be very diplomatic in your answers and solve the query then and there. Solve the anything which is coming. If losartan has come, you would have, cleared the concept over there only. That losartan is that's a very good drug. I can see you are happy with it. But when you're pregnant, we switch it with a safer drug. Will that be fine if I put you in touch with your doctor now, heart doctor, and he can, we can start a safer drug for you, or you can start it by your own, but you always have to involve the heart doctor. So you can tell her that we will switch this drug, stop this, switch it on labetalol tablet, which is a safer drug in the pregnancy. But I would first book an appointment for you with the cardiologist as soon as possible, maybe today or in a day or two, whenever earliest we can find it, so that patient knows that it's not a safe drug, but doctor is helping me by booking my appointment immediately, and she has the concerns for me. So you can always speak like this, okay? I do this in my OPD also, like when I'm seeing the patient, and any patient has any doubt about the medicine, or anything like, doctor, I'm not happy with this. Will this affect my baby? Then what I do is I call my colleague on phone and I tell them, you know, I'm sending you this patient. Just make sure you you attend her on time, and because she's pregnant, so it is kind of a like we have to expedite it. So like this, you know, you can help her. Losartan, we can switch it off. Propranolol, yeah, it is a good drug to, you know, keep your heart rate in check. Because when you have this Marfan syndrome and it is affecting your heart when you're pregnant, the blood flow and, you know, volume, it increases, and the load on the heart increases. Your heart rate also increases. So these two drugs, like one for blood pressure control and one for heart rate control, are really good. Then you have done and dusted the matter, you move on. Just ask about the present pregnancy detail, and few points over there is, this is your first pregnancy as you told me, and this is unplanned, so we'll put you in touch with contraception clinic after your delivery, so that these kind of unplanned pregnancies doesn't happen, and we enter in pregnancy in a like planned way. Okay, so how many weeks you are, were your periods regular, and if you find your time is less, then you can skip that gum clinic and STDs. It is of no use here. Just ask about the periods, just ask about the smears, because smears are a cervical screening national program part. So you need to check that. Do you have any drug allergy and blood group? You have good support. You covered those things. When did you meet your doctor last? What about your heart scan? And are you able to, you know, do your routine activities? She'll say yes. Okay, you know that she is NYHA 4 or 3, so it's good. Okay, I mean, she's able to do her work. Then about the risk, even if you're that, you will talk later. Then yes, now coming on to the, you took the history, you did the right thing, you asked about the family history. Rather than congenital, you can ask genetic. Have your partner being tested for Marfan syndrome? Has he been tested? If not, then you will put him also for the testing, okay, with the genetic counselor. In the family, anybody has Marfan syndrome, ask directly. Okay, any clot history, blood pressure history, and sugar history. That's it. Then we will examine you in the presence of a chaperone. I'll check your heart, check your lungs, and also, you know, hear your heart and lung. And then we'll take your blood pressure and pulse. My nurse will take that. Will that be fine with you? She'll say yes. Then you move on. And try to kill the thing over there only. Do not carry forward, because in these stations, you just get lost in the station. And it is very difficult to come back again and again on few things. Okay, even if you write it in your notes. So now advise her to continue. Now in applied clinical knowledge, first manage this pregnancy. Continue the folic acid. I will, and you know what, Mrs. John, I would like to tell you that this is a genetic condition. Genetic means it runs in family. Do you know that? She'll say yes or no, whatever. Okay. So the chances of having, you know, if you are having this, then chances of having it in the baby is 1 in 2. So 1 in 2 means 50% almost, right? If your partner will also come positive, does he have any sign and symptoms or any medications? She'll say no. Okay, but we'll still get him tested. If partner is also positive, then there are 3 out of 4 chances that the baby will be affected, like 75%. Then if she gets disturbed, then say, I will put you in touch with the genetic counselor. You have to, you know, be expressive, and you have to show that you are there. But what is there is there. You can't hide anything. But yes, empathy element and concern. These are the 2 things which will help your patient to pick her up. Okay. So you will say, okay, I'll put you in touch with the genetic counselor. She will explain you about this in detail, right? And she'll say, what if my baby will also have it? Then you say that baby can lead a normal life as you are leading, right? So that can be managed, Mrs. John. Just don't worry. But whatever is there, you can, the chances are 50%. 50% it can be normal as well. Genetic counselor will make it clear to you and you can take your decision accordingly. That's it. And you move on. Don't say any word like termination or support or anything like that. Okay. And now coming on to another point is genetic, you have to kill it. Okay. You have to solve it. And after that, you need to say that in Marfan syndrome, do you have any idea about what is this condition? She'll say, yes, it affects the heart and my joints also aches and pains sometimes. Okay. Do you have any vision problem? She'll say yes or no. Okay. And then you can ask her that, you can tell her that it's a connective tissue problem. Connective tissue in a simple form, you can say it is a supportive fibers which support our joints, our tissues to keep it strong. So when the fibers are weak or defective, then organs also become weak and defective. Mainly it affects few of the organs like eyes, joints, your heart, and there are blood vessels which are taking huge amount of blood from the heart to the body. So the root of that vessel, which we called aorta, that root becomes weaker sometime and it becomes dilated. But as you said, your echo is normal. I would like to see what is the exact diameter, because if it is less than 4 centimeters, we are happy generally that it's low risk. But still there are 1 to 2% chances that it may lead to complications, right? So like this, you have to tell her. And complications can be in the form of weakening, and then there can be, a tear also in the blood vessels. So the blood doesn't go out. In fact, it comes out in the body. So that lead to a shearing pain and in the chest, and that is in fact very, very lethal condition. It is an emergency to deal with. And it sometimes, some of the women may lose the life as well, though the chances are less, but it is there, Mrs. John. I need to tell you this. I don't want to scare you. But if at all, continue simultaneously tell that what she can do to, don't wait for her to be scared out of this. When you break that, you may have, this aorta can shear off and there will be aortic dissection and you will die. You have announced that already. Don't repeat it. Don't go back. Don't give her time and just switch on to. So we advise you, and don't tell her that with you this can happen. Some women develop this tearing and they can have, this pain in the chest, and sometimes it may lead to the death of the woman also. But so we advise you, if you feel any palpitations or increased heart rate, or any chest pain or breathlessness, we advise you to quickly come. Do you have your transportation available every time with you? Do you stay nearby? Okay, so like that you have to assess her safety and transportation. It will give you additional marks. Then you will you have done the safety netting, which was the most important safety netting, right? And now tell her that whatever medication, this heart rate medication, will not affect her baby's growth. Risk of the baby, we have told her. Now coming on to this disease, apart from causing this this aorta problem, it can also lead to heart failure, because sometime, a heart start pumping more, and it is weaker because of the connective tissue defects. So it may fail as well, but the chances are very less. This is a complication of this disease, which I need to tell you. You may feel more joint pains and aches in the pregnancy. Also, you may have palpitations or increased heart rate, then we'll put you in touch with cardiologist again, and your propranolol dose we can adjust accordingly. And if any other drug also need to be added, we'll add that. So baby may grow small because of the defect in the blood vessels. So sometimes they pump less blood to the afterbirths, and blood goes slow to the baby. So baby may grow small, may come early. The blood become thicker in pregnancy, and the flow is already become slower because of these fiber defect. So the clot formation may increase from the usual during pregnancy. We will put you on this thing, low molecular, we will put you on blood thinners. Okay, if you have any confusion about any whether when to start blood thinner, if we have to speak about heparin, if we have to speak only about ecosprin, just say we will put you on blood thinners and come out of the situation, right? You will get a tick on the blood thinners and you'll get your point. So like this you have to explain. Now the course of pregnancy, it will be in a multidisciplinary team, it will be a high risk, this thing. The delivery timing, we will decide about the delivery in during the pregnancy. We'll decide that when you will deliver according to your condition. Okay, otherwise it is not advisable to deliver you before time. If there will be any concerns with the baby or with you, then we may advise you to deliver before time or between 38 to 39 weeks. So like that you can explain her. We will make shared decision with the anesthetist doctor, with your heart doctor, and me, my consultant, your GP, your partner. Will all sit together again and make a suitable plan for you. For your delivery as well, we'll make a plan early, on time, so that we have everything ready for you. And whenever, even if you come in emergency, we can provide you best care and a safe environment. Your safety is our priority. You can add anything like that if you have time. Okay, and just talk in a relaxed way. Make her feel relaxed. She is already disturbed because you have told her about the baby, that baby may have the disease. You have told her about this thing, what do you call, the partner, and the chances may increase. You've told her about the aortic dissection. You've told her about the losartan. You need to give her time to digest everything. You will tell her that we'll give you written information in the end, and also tell her that next time when you will deliver, when you will deliver, you can breastfeed the baby. If the baby there can be recurrence of in this, though there is nothing to recur. Yeah, this is nothing like that. Okay, this is autosomal dominant, so I'm confusing myself, is confusing with SLE. So the thing is that you need to explain that she can breastfeed, she'll have a good contraception, and in the next pregnancy there is a possibility, there is a thing which is called pre-gestational testing, PGT. So because she has that condition, NHS will support you. If this baby will not be having any problem, then that's okay. Next time PGT will not be sponsored by the NHS. Otherwise, NHS will provide you the facility of PGT for having one baby without Marfan syndrome. You can avail that, and in that we can. It is kind of an IVF procedure. We take out the egg from you and sperm from your partner, fertilize it in the lab, check whether it is having the affected gene or not. So any embryo which will not be having will be transferred back to your womb. So we make many embryos, and we took the healthier one and put it in the womb, right? So this is how we can you can go for the next pregnancy. If at all, if she asks you about the baby and she is asking too much about the baby, then you can tell about the PGT option, right? That you have this option available. So otherwise, don't get stuck anywhere. Just go quickly and tell the important points. Okay. PGT will not carry any mark here, because it's like when patient ask, if they have given a mark, then patient will ask you, what can I do if my baby will be affected? I want a normal baby. How can we do anything? Then you can give her the option of PGT, right? Otherwise, in any of the case, don't go for the complicated thing. Okay. So that's the end of this station from my side. If you have any query, you can tell me, and I'll be happy to solve it. And also, there is a very important announcement which I want to do. Whoever are joining the session right now, we have a 30% off on our MRCOG Part 3 course, though I think it is already a very economical course. So, because our aim is to, give you the best benefit of the knowledge and of the skills which are required for the MRCOG Part 3 exam. So, this offer is valid for next 48 hours. And believe me, you all will be benefited by the course, and will sit with you, will learn with you, will teach you, and will make you in a perfect way to face the exam. So if anybody want to join, it is for 48 hours. You can join it, and you can, our team will be in touch with you. So any queries from anybody? Okay, so shall I think that I was very understandable?
Excuse me, if I said about this preeclampsia risk, but there isn't increased risk preeclampsia, is it a mistake and I will say I will have negative point?
Negative points you will never get. This is not a exam of negative points. You'll not get negative point. Okay. In a simulated patient task or in a structural discussion, there is no negative points, only positive points. So this is a positive point for you. Though you, I know I've written it here that it's not like the preeclampsia thing will not come here, but that's okay. If you have spoken something, don't justify, don't go back, just say another thing. Okay, no negative points, just positive points. So you have a lot of scope, just stick to the map, stick to 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Learn it, revise it, learn it, practice it, and you'll go through it. We will give you templates which you will just read and you'll learn and you'll go through it. Because the syllabus is huge. The only thing is, syllabus is huge. You need 3 to 5 good months and a good help also. You need, for MRCOG Part 3, you need a good help, good support, and good understanding of the subject. That's it. And you are through it. Believe me, this is an exam which need to be cleared in first go. And you will clear it just with the proper right direction. So this is what I want to say. All the best for your exam bookings and exam in future and your studies. For now, you just have to start studying, and later part will come later. So we'll be in touch. We'll keep on conducting these kind of webinars, and I hope you all will be benefited. Thank you so much, Team Med Expert.
Just one
Thank you so
question.
much,
In
Dr. JP. Thank you so
side,
much.
there is some several MRCOG3. There is also mock exam for different for example UAE. And can you explain it? What is this? Is it available from now or for later, or how it is? How does it work? What should we choose?
Natalia, you choose what clicks to you the best. Everybody is trying their best to, keep you motivated and teaching. But I would say, if you will ask me, I would say you join me. Right? Jokes apart, but I'm sure that whoever will come to me, I'll teach them the best. And I'm so confident because till now I have given offline teachings only. So I'm in India, but everybody has cleared their exam. So I'm confident that, that's why now I have joined the online platform as well. So rest, do not go here and there much. Stick to one course which you feel that, yeah, this clicks me. I understand the points. The language is understandable. The material I'm getting makes sense. It's not just the material. It has the, points for us. It will give us a right direction and right, you can say, we can hit right with that material also. Everything will be available online, but your eyes should see that and your brain should know that what to see. Suppose if there is one line in a slide, it's not just one line, it carries a lot of weightage, a lot of, and you can get 6-7 marks from that line, right? A simulated patient task will be of around 30-35 marks, and the structural discussion will be 12 to 15 marks. So the marks are divided like that, right? And you have to earn maximum. But let me tell you, Natalia, you have a basic grip on the subject. Let me give you compliments. So you don't think that you need to learn a lot. You just have to go systematic and you are through it. Okay? You will be through it because you have really presented very well. If I can see that from a mentor point of view, that you were doing well, you have the grip and you know the subject. So just a bit of rebrushing and you will be better. Don't get confused. Don't go on every platform which is available online. Have faith in yourself. It is only about practice. Practice, repetition. If you have a partner, study partner, well and good. If you don't have, your mirror is your study partner, right? Record it, listen. Record it, listen. Listen to as many as possible. Record yourself. Read a reliable. Make your own template. Make your own style, and don't worry much about the reading. Worry about the presentation, and you just have to be presentable and knowing what you have to speak. That's it. It is only about your communication. Maximum marks you will get of communication, believe me. If you are a good communicator with your, as in your structural discussion also, in your patient cases also, if you communicate well, you will nail it. So main chunk is communication. Focus on that. Focus on that. Study wise, with whatever material we will provide you, whatever slides we will provide you, will be more than enough. It will be plenty material you will be getting. So just read that, which is important. Just read that. It will be already marked, and just focus on your communication, right? It is not a rocket science. It's just A, B, C, D, E, F, G, H. You should know the sequence of alphabets. That's it. Any other thing I can help you with? And be relaxed. Keep walking. Keep on doing. And it's a fun exam. It's a good exam. I'll tell you, I have enjoyed the most in MRCOG Part 3. And I hope you guys will also. Okay. So shall we call it off? Or there are any other queries or anything you want to ask or we want to chat about? Anas, should we call it off now?
Yes, ma'am. I think it's all done. Thank you very much for this wonderful webinar, ma'am. Thank you very
My
much.
pleasure. My pleasure. Thank you. Okay,
Thank
everyone.
you.
Yeah. Bye. Take care.
Bye. Take care.